The topic that I have been assigned is more of a theoretical topic, so I'll be taking you through the chapter of Harrison's. I can give you the exact reference, chapter number 403, 21st edition, Harrison will be talking here, and we'll be talking about diagnosis, classification and pathophysiology of diabetes. I'm so sorry, I will not be taking through the clinical case scenario. It's a theory topic, we'll just go through it as theory topic only. Maybe it can help you somewhere if you are preparing for any of the entrance exams, maybe NEET PG or NEET SS, maybe your MLE or somewhere. So that was the idea. Can I have my slides, please? Yes. So the very first slide will just tell you about what is diabetes, the simple diagnosis or the simple definition of diabetes as we all know it. A condition of hyperglycemia. A condition of hyperglycemia, and that is because of either insulin deficiency or deficient insulin action. That is, either there is insulin resistance, or there is hyperproduction of glucose by the liver, or decreased utilization of glucose by the skeletal muscles and the adipose tissue. So the spectrum of hyperglycemia is what we commonly know as diabetes mellitus. So that is what we are talking here. This is further classified into broadly, this is a table which is a bit difficult to read here, so just simplify this in this manner, that it is classified as type 1, where we are talking of entire insulin deficiency, autoimmune destruction of the beta cells, type 2, which is more of insulin resistance to begin with, and which progresses finally to insulin deficiency when there is hyperglycemia. Then we have the third variant, that is gestational diabetes, which happens during the last trimester or the end of second trimester of pregnancy. It is because of the pregnancy hormones, the counter-regulatory hormones causing hyperglycemia. And then we have the fourth group, which includes all the other variants of hyperglycemia, all the other causes of hyperglycemia, which may include even endocrinopathies, or they may include the secondary diabetes, any damage to the pancreas, even the genetic, the monogenic forms of diabetes, other all variants, they have been clubbed together under the broad heading of other types. So these are the four variants they have been described. This is the global burden of diabetes. As we know, we are having an increasing projection every year, and we are facing a still further increased number when we come to that year. Then comes the diagnosis. How do you diagnose diabetes? So we classify normoglycemia as a fasting plasma glucose of less than 5.6 millimoles per liter, HbA1c less than 5.6%, and 2-hour plasma glucose less than 7.8 millimoles per liter. Then we have hyperglycemia or dysglycemia to begin with, that is a stage of pre-diabetes. So as long as the fasting plasma glucose remains between 5.6 and 6.9 millimoles per liter, we classify that as impaired fasting plasma glucose. Then HbA1c between 5.7 to 6.4, and 2-hour plasma glucose, that is 7.8 to 11 millimoles per liter, is IGT, that is impaired glucose tolerance. Anything above that is frankly overt hyperglycemia type 2 diabetes. So HbA1c above 6.5, fasting plasma glucose above 7, and 2-hour plasma glucose above 11.1. So that is how we diagnose diabetes. Now, when do we screen and whom do we screen? Do we just go on doing it for everybody? So again, there are specific guidelines. So all population who are at risk of type 2 diabetes, maybe they are overweight, having a BMI above the standard cutoff, that is 23 kilogram per meter square, having a strong family history of type 2 diabetes, Ethnicity plays an important role, especially we Asians, we are at higher vulnerability of type 2 diabetes. Then we have insulin resistance, features of insulin resistance evident. Increasing age is an important factor for developing type 2 diabetes. So these are all risk factors which deserve to be screened for type 2 diabetes. Now, why these cutoffs are taken? Why we are talking of some specific cutoffs? We are talking of these cutoffs based on data analysis, and the literature review says that fasting above 116 marked the beginning of retinopathy. Similarly, 2-hour plasma glucose or 2-hour postprandial glucose above 185 marked the beginning of retinopathy, and HbA1c above 6 marked the beginning of complications, the micro and macrovascular complications. And that is why these cutoffs were designed and they have been followed. Now, what is the regulation of glucose? Like, how is the glucose homeostasis maintained? So, other than the hormone insulin, there are other players. There is glucagon playing another important role. Then there are neural signals besides the humoral signals. The main organs involved in glucose homeostasis is brain, which controls the appetite and the satiety center. Then we have liver, which has increased glucose production, or it makes gluconeogenesis feasible, or it stores the extra glucose in the form of glycogen. Similarly, we have the peripheral tissues, that is adipose tissues and the skeletal muscle, which utilize glucose under the influence of insulin. Then we have, of course, the pancreatic alpha cells releasing glucagon and the beta cells releasing insulin. So there is a very intricate balance, signal circuiting of neural and humoral signals that leads to a well-balanced blood glucose levels, and anything going disrupted anywhere will lead to hyperglycemia. Now, this is a very busy slide, so we will not go into this. Rather, I will make it simple for you that how is insulin synthesized. So, to begin, we have the gene here. This insulin gene, the initial insulin molecule is an 86 amino acid polypeptide chain which is released in the form of pre-proinsulin, and from this pre-proinsulin, it is the signal peptide is removed and we have proinsulin. From this proinsulin, we have removal of this internal C-peptide molecule, and the alpha beta chain they remain, which is the mature insulin molecule, and they are bound by the disulfide bonds. Now, how does this insulin secretion actually happen? Again, I will take you in a pictorial manner. So, this insulin secretion in the beta cells begins from here when the glucose enters. This is a glucose mediated signaling, and the glucose enters the beta cells mediated by the GLUT2 receptors, and inside the cell there is glycolysis happening. This is the rate limiting step under the influence of glucokinase, and this ATP is generated. ATP sensitive potassium channels are closed and the voltage mediated calcium channels open. So, the calcium comes inside the beta cells, that is calcium influx, and this calcium influx causes the pre-stored vesicles to rupture, which already had the pre-stored C-peptide and insulin. So, this insulin and C-peptide are released into the system. C-peptide is slowly metabolized, so it remains longer in the system, and that is why we check C-peptide to find out whether the source of insulin is endogenous or exogenous. Then this insulin which is released from the beta cells, this is actually entering the portal vein, and 50% of the insulin is metabolized in the liver. So, the portal system and the systemic circulation insulin ratio is 2:1, and the 50% of the remaining insulin that enters the systemic circulation then acts on the insulin receptors in the peripheral tissue, that is skeletal muscle and adipose tissue. Now, at the level of skeletal muscle or adipose tissue, how does it act? This is the insulin receptor. The insulin will come and bind here. It will stimulate the tyrosine kinase, the secondary messenger system tyrosine kinase, and there will be, you will have to remember the slide because the diagnosis of diabetes and management will come from here. So, inside the cell there are secondary messengers, the tyrosine kinase stimulates the IRS system, that is insulin receptor system, which will stimulate the phosphatidylinositol 3-phosphate system. This will cause cellular growth. This is through MAPK pathway. And during hyperinsulinemia phase, this mitogenic pathway is stimulated more because of hyperinsulinemia, and that leads to atherosclerosis. Whereas in this pathway there is growth, protein and lipids and glycogen synthesis. Then there is lipolysis happening, and this GLUT4, it is again transferred to the cell membrane surface, and this GLUT4 receptors, they are shuttled out on the surface and they bind the glucose, and this way the glucose enters the cell for utilization. If this does not happen, this glucose remains in the blood and we face hyperglycemia. This is how the insulin action actually happens. So now coming to the type 1 diabetes, that is pathophysiology of type 1 we talk of. Now type 1 diabetes is a complex interplay of genetics, environmental and immunological factor. It can develop at any age. Whenever you diagnose more than one antibody already in the system, that is not type 1 overt, that is just the stage of type 1, stage 1 of type 1 diabetes. At that point of time, there may not be hyperglycemia. Then begins the dysglycemia, and mostly around puberty, this is the highest peak duration of development of type 1 diabetes. Then there can be a period of honeymoon phase when the residual beta cells start functioning again. Never get confused with the C-peptide levels, because in some patients some amount of C-peptide might persist till late in the condition of type 1 diabetes. So this is the pathogenesis. There is complex interplay of the genetics plus epigenetics plus environmental factors, immunological factors, which lead to T cell infiltration of the islets of Langerhans causing insulitis, and the T cells that are infiltrated, they are responsible for T cell mediated beta cell death. The antibodies are formed because there is activation of the humoral system as well, but those antibodies are not directly responsible for beta cell damage. So there is a phase where we have a preclinical phase of type 1. So there is genetic predisposition. On immunological trigger, you will develop antibodies. So more than one antibody present in the system is stage 1 or stage 2. At this point, if you treat with teplizumab, which has been a trial for 14 days, you can prevent the progression to stage 3 for quite some time. Then when unmasking of hyperglycemia happens, there is dysglycemia, and finally type 1 diabetes, when beta cells are completely damaged by the CD8 plus T cells. So it is T cell mediated damage of the beta cells. Coming to the genetics, it is the chromosome 6 which is involved, and this is the HLA complex, the MHC expression gene, the MHC class 2 genes, especially the DQ subregion, which is predisposing to the development of type 1. But at the same time, there are some preventive DQ regions also, or the chromosomal regions also. So genetics is involved in type 1. This genetically vulnerable population, when exposed to environmental triggers, will develop antibodies, will have insulitis, and will lead to beta cell damage. And that will cause frank type 1 diabetes. Again, a pictorial representation of the same thing: genetic susceptibility, environmental triggers causing insulitis, leading to the formation of anti-islet cell antibodies. Anti-islet cell includes your GAT65, zinc-8 transporters, or IA2. There are many non-islet cell and non-HLA antibodies also which are involved, like CTLA4, PTPN22. Then there is a phase of pre-diabetes. Still the sugars are not high. It is only when the type 1 diabetes becomes overt and the child presents to us with either diabetic ketoacidosis or a stage of hyperglycemia. This is about type 1. Coming to type 2. In type 2, there is more of insulin resistance to begin with. But insulin resistance is combated by hyperinsulinemia. So diabetes only happens when there is decreased insulin synthesis and secretion. So in the initial phase, you will find as the insulin resistance is increasing, hyperinsulinemia is increasing. At this point, if hyperinsulinemia fails to happen, then it is the time of IGT, and then it is the time of type 2 diabetes. So insulin resistance is the primary defect in type 2. That does not mean that there is no genetic component involved. There is a genetic component in type 2 also, and that is why the family concordance rate of type 2 diabetes is very high, up to 70 to 90%. And most of the first degree relatives will also have impaired glucose tolerance. But still it's a polygenic and multifactorial, and the most important organ that plays a role in type 2 is the placenta, the epiphemeral organ, which is a temporary organ but plays a very significant role because of either the overnutrition or the undernutrition. So, we have a lot of factors responsible here for type 2 diabetes, and pathophysiology is marked by insulin resistance, then there is deficiency of insulin secretion, and finally there is hyperglycemia. This is one important factor which I already told you. In the stage of hyperinsulinemia, there is mitogenic pathway activated leading to atherosclerosis. Besides this, there are other many under pathophysiological defects which are underlying to begin the beta cells, of course, even alpha cells. There is hyperglucagonemia. Then there is resistance in the adipose tissue level, skeletal muscle level, and the hepatic level also. And this is responsible for the development of NASH. I am rushing because the time is ticking. Then we have the brain, which is playing the hypothalamus, which is playing a role by decreasing your satiety level and increasing your appetite. At the GI level, there is blunting of the incretin effect. So, there is less effective role of GLP and GIP. Inflammation plays a role, immune dysfunctioning plays a role. Then we have the defects at the stomach level because of the gastric emptying is fastened and the patient is always hungry. Adiposity, that is again obesity, is a component of, I will just take another minute just to finish this. Obesity is another important part of type 2 diabetes, and obesity plays an important role by increasing the inflammatory markers and decreasing adiponectin, which is an insulin sensitizing peptide. Now, this adiposity, this is again playing a very important role, that glucose per se paradoxically will cause further beta cell damage. So, that is glucotoxicity. Similarly, the high fats, the free fatty acids which are higher in level will cause lipotoxicity and cause pro-inflammatory factors to come in play and will cause beta cell damage. Resistance at the liver level and at the adipose tissue level will cause increased VLDL and increased triglycerides, and they are responsible for the metabolic associated steatotic liver disease, that is MASLD as we call them. We have variety of insulin resistance syndromes. So, we have the type A, which is seen in PCOS girls. We have type B IRS syndrome, where we have antibodies against the receptors. We also have post-receptor defects in the form of type C insulin resistance syndromes, and we have lot variety of syndromes. I am not going into them. So, you can you come across them in your daily practice. Then comes the role of prevention. Yes, type 2 diabetes can be prevented, and DPP, that is Diabetes Prevention Program, which was a very big trial, which led to the conclusion that lifestyle modification can help us in delaying or postponing development of type 2 diabetes. The last form, that is MODI, which is a monogenic form of diabetes. We have more than 14 variants. Just to mention a few, the MODI type 2, which is a glucokinase mediated, does not require treatment because the set point of glucose is raised. So, a little high level of glucose is required to open the calcium channels and release of insulin. Similarly, MODI 3, it responds to sulfonylurea. MODI 4, it is a homozygous defect, will lead to pancreatic agenesis. Heterozygous defect will lead to diabetes. MODI 5, this is the one which requires insulin. Neonatal diabetes is another variant, that is diabetes developing within the first 6 months of life. It can be transient, it can be permanent. If it is permanent, it will overlap with clinical picture of type 1. If it is transient, it will go away after 6 months. Then we have certain mitochondrial diabetes, mitochondrial mutations in the form of Wolfram syndrome, that is the DID-MOD syndrome, diabetes insipidus, diabetes mellitus, optic atrophy and deafness. Then another variant is the MIDI, that is the mutant insulin gene diabetes of the youth, that is the MIDI's variant. So, these are the various rare variants of diabetes. With that, I thank you all for having me here. This entire content has been taken from reference 21st edition Harrison's. Thank you.